like we have a number of people watching live. If anyone wants to hop on, I see Andy's here. I'm sure Andy has lots of questions for you. Stephanie's here. A lot of good people online. Marcy, if you guys want to hop on, feel free to hop on. You can join. There's 2 open seats. We're happy to have anyone join the after party and ask questions of Dana, myself, or even just share your own insights. If you don't want to hop on camera because you're shy, kind of like me, I'm a shy person, you can also put /Q and then space and add a question that way. We've had a few people actually already ask questions. So Roxanne asked the question, how long did the office hospital have the IT, and then you would have to search for old records? I think if I understand it right, she's asking how much time was spent searching for old records. I'm sure you have some experiences from all your time working in hospitals before EMR. What were some of the trials people went through back in the day before EHR?
Oh gosh, I remember I spent a while as interim CIO at MD Anderson, and I remember we used to have such large patient records. We'd have patients who would come for treatment for years maybe, and their records would get so large, we'd have to transport the record from maybe the hospital where medical records was over to the ambulatory center for treatment. And I would see people pushing the record in a wheelchair because it was so big across the ambulatory center. And so, I mean, that's just, imagine.
Wow.
And without it, how could you find anything in it? So
I've always said credit those HIM people, 1, to be able to find the record, and then 2, to find the piece inside the record and the way they filed it. I mean, really, they worked some amazing magic considering the limitations that they had. Yeah, my favorite one in that is actually the finger pointing, right? I didn't have the record. No, you had the record. No, I had the record. Wait, it's under my coffee on my desk. Oh, maybe I did have the record. It's like, none of that anymore. So there's definitely advantages there.
One of the first hospitals I worked with had a very famous cardiac surgeon who was on staff there. And we put in a radiology system, and the radiology system tracked who had films checked out, and if you checked them out longer than you were supposed to, it sent warning notices, and eventually said your privileges are going to be suspended if you don't get these films turned, if you don't get the chart turned back in. Well, we had to do an enhancement to the system to exclude this one cardiac surgeon because he was so famous that he could keep records as long as he wanted to. And if anybody else needs it, it was just too bad.
The famous physician rule at play. It's amazing what they'll do for the right person. I think that's true in all parts of society. So interesting. So Diane Bernard asked a question about sharing data between payers. And I think that's interesting, just to kind of blow that question up, we've seen such an interesting evolution of the payers. I had one friend, Steve Cisco, who works with the payers, and he states that almost de facto payers will become providers. And from the other end, when you look at value-based reimbursement, you could say, well, providers are becoming payers. So, although, as a patient, I get afraid at the idea of sharing too much data with my payers because I think they're going to discriminate, they're going to charge me more. But, all of those fears, whether they're true or not. How do you see that playing out, sharing data between payers and the integration?
Well, you're right. The lines are blurring there. The payers are becoming providers. They're buying practices. I drive down the street and I see practices here in Houston that are owned by payers. And providers are becoming their own payers. So, I think the lines are definitely blurring. and it makes it very complicated about who to share with, who to share data with, and when it's okay to share data. I was in a discussion yesterday with a number of leaders from a community, and the discussion was around population health, and it was like, the proposal was maybe we should get together and see how we can kind of do population health, and at first it was like everybody was sort of, oh, that's great, let's all share data, and then all the problems began to come out. Well, are we going to share
everything?
Are you going to know about my healthy patients? Because you might want to steal them to make, put them in your plan so your numbers are better. And, when do we have to have IRB approval? And, all of a sudden it got very, very complicated. And what was a high, lofty goal of let's improve the health of a population became fraught with complications.
That's really interesting. It brings to mind two things. I recently wrote an article that the biggest challenge to healthcare is excuses. And the premise of that was that healthcare is so complicated that if you want to find an excuse, you easily can, right? I mean, that it's when you're dealing with complex problems, there are plenty of excuses. And so we often just take that excuse rather than trying to work through those complications and find the solutions. I was talking to a CMO, which I think is related to your example. And he said, it's great that people are talking about FHIR, and maybe it's a progression beyond HL7 and through NCCDA and some of those things, right? But it's really just a progression. It's not a transformation of interoperability. In fact, he argued that we still aren't changing any of the dynamics for why people don't want to share. And so, even though the technology is better, it may facilitate certain interactions and certain, flexibility. He said it really doesn't solve the interoperability problem in almost any way substantially. And he argued that really, we need these, I think he described them as these health data banks, right? Which there's some already out there, where it's like everyone's required, ship your CCDA for every patient to this health data bank, and everyone can access that, and I said, okay, well, that's great. I think we all agree that would be beautiful, right? As a patient, I would love for it to be there, to be de-identified in a way that's reasonable, to be held private and secure, have it there whenever it's needed, and when it's not needed, it's stored safely away. I was like, but I don't see any pathway to actually getting there. Barring some government, you have to do this, and we know how the government works on getting those type of approvals. Anyway, thoughts on, do you think that we're moving forward in interoperability? Is that a feasible solution? Thoughts?
Well, I go back to your comment about any excuse will work. People right now really are, stymied by excuses. I remember we were trying to do a project years ago. A guy named Bernie Menard, one of my favorite people, was CIO at Methodist here in Houston. We were trying to get several hospitals to share data, and we had identified some issues, like who was going to be responsible for protecting the data. I don't remember all the issues, but finally Bernie said, look, we could sit here all day and identify problems, but if we want to do this, at some point it just comes down to trust. And I'm willing to trust the people in this room that will make this work. We'll figure it out. And he signed the contract and took responsibility, and they made it work. And for years, there was a collaborative EMPI in the Med Center here in Houston. And it was based on that statement that he said it comes down to trust.
I think that is the challenge. And unfortunately, we're in an environment where there's a lot of people that don't trust it. I like to describe it that, I use the Hunger Games example. I feel like sometimes in business, I'm Katniss and I have morals and principles and values, and I'm working in an environment where a lot of people don't. A lot of people are doing whatever it takes to win, and they don't. There's no rules, and they live that way. And my only my favorite part of the story, though, is that Katniss wins. So, I think you can have morals and values and be ethical, and I've found if you find the right people to trust, you can trust them, and and everyone benefits. So that's probably a great message for healthcare.
Well, I'm naive, but I still like to think everybody's got good intentions. We just sometimes have a different set of objectives that we have to try to reconcile.
Yeah, and I think you have to remind people of it too, right? What is the real goal here? And I think that's the important part in healthcare. Well, thank you so much for your time. I want to wrap this up. Again, we've been here with Dana Sellers, CEO of Encore, a Quintiles Company, and it's always a pleasure learning from you, and we appreciate you sharing your wisdom. So thanks for coming on.
John, always great visiting with you, and look forward to seeing you.
Definitely. Thanks, everyone that joined live. This will be recorded on healthcarescene.com. You can find the recording also on our YouTube channel, and of course, we'll tweet it out on social media. Thanks. We'll do it again next time.